Morning, everyone. I can see that people are starting to come into the webinar. So we are just starting a couple of minutes late, but we are going to kick off very soon. My name is David. I'm from Cardiff University. I'm really just here as host, so you haven't come to hear me speak, so I will be very prompt and hand over to the people that you have come to hear speak. So we're very lucky this morning to have three very good presenters with us, and I'm looking forward to their session. So we have Sofia, who's a research fellow at Lab at Cardiff University. We have Anne, who's a former children's social worker and diversity information officer at the Alzheimer Society Cymru, now working at Promo Cymru. And we have Suzanne, who is Black and Minority Ethnic Mental Health Services Manager at Diverse Cymru, and they're going to be talking to us about the topic of health inequalities and dementia, particularly in relation to the question of what matters to people living with dementia and their families. So the presentation will last for around about 40 minutes, and then there'll be time for questions, comments, thoughts from the audience after that. If you do have any of those things, then please post them in the chat box, and we will field those at the end on something like a first come, first serve basis, but we'll do our best to get through as many as we can, of course. That being said, I'm going to hand over and listen to the presentation and look forward to it. Thank you very much for everyone who's here, and thanks to the presenters.
Thank you very much for the introductions, and thank you everyone who is joining us today. As it was earlier introduced, you know, our strength is also our diversity, and the university working together with the third sector, with community groups and with dementia champions to really try to understand what matters to people living with dementia and their families, and how do health inequalities impact upon dementia care and those experiences. So what we'll be sharing with you today is some findings from our year-long collaboration. So as it was mentioned earlier, I work at Lab, which is a partnership between Cardiff University and Nesta. We are specialists in arts and health and using creativity to humanize the research process, but also to communicate findings in impactful ways and change the way dementia care education is delivered. Suzanne from Diverse Cymru is a specialist in BEM mental health and worked as the underrepresented communities engagement officer at Alzheimer's Cymru. We also collaborate with Sarah McKee, who is doing this role now. And of course, it all started from our existing program of research on dementia care in hospitals at the School of Healthcare Sciences, whereby we understood, it was very clear to us that underrepresented groups are not part of our research, and we needed to do more to be able to understand how do people want to be involved, and what is the best way to do that. So how did that happen? Sorry, I've got an introductory slide about what is dementia for the participants who are working in different fields. So dementia is a general term for memory loss, language, and problem solving. Alzheimer's disease is one of the most common causes of dementia. So sometimes those two words are used interchangeably, but they're not. Dementia is progressive, so that means that the symptoms accentuate over time, and it's caused by damage to the brain cells. So recent memories go first. So one of the challenges is about addressing the distant memories in which people with dementia are living. And also it's important to know that diagnosis is a process. There isn't one test that just does that. And Suzanne will talk now a little bit about the population impact of dementia.
When we come out of these lockdown meetings, we're going to be lost when we're not going to say, you're on mute. Yeah, and sometimes I'm going to wish people were on mute, I think, when we come out. Anyway, so sorry, we'll start from the beginning anyway. As you can see, in 2015, dementia overtook heart disease and stroke as the UK's biggest cause of death. And even that was a massive surprise to me. In 2017, it was one of the top 4 causes of death, along with heart disease, stroke, and lung cancer. So in itself, that this is a pandemic, it seems to me, that dementia is. The most common pre-existing condition for people who are dying from COVID-19, and for the 25,000 people from the Black, Asian, minority ethnic backgrounds living with the condition across the UK. It is estimated that in the next 40 years, there'll be a 7-fold increase in the Black and minority ethnic population and only a 2-fold increase in the white community.
So health inequalities in dementia care is an area that is, it's quite new, it's quite under-researched as well. There is very limited research on actual dementia care experiences of underrepresented groups, but there is indication that there are low levels of awareness about dementia and that there is stigma among some minority ethnic communities, which can also result in diagnosis and services being requested much later. We also look, so more specifically for deaf people's understanding of dementia care as well. A lot of the resources are not available in the BSL, British Sign Language. And the Alzheimer Society is doing some pioneering work in translating a lot of the resources into signed videos. Similarly, the LGBT older adults face distinct risk factors such as social isolation, discrimination, and barriers to healthcare services. And this is something that has been described as a double stigma, which means that there is a duality in managing dementia and managing a minoritized identity, all within a context also of societal discrimination. So when we worked across equality strands, we were interested in also what are the similarities and what are the differences as well. So we were very fortunate to be able to secure funding from the Higher Education Funding Council for Wales, the Enhancing Community Engagement and Civic Mission strand. And that enabled us to create this bespoke project. And first of all, start by community engagement awareness meetings. It was very difficult to identify people with dementia from underrepresented communities. So we started by putting ourselves out there and giving something that's useful for people, which is starting the conversation, delivering some friend sessions in different settings. That was followed up by one-to-one group interviews with 20 people, their children, their friends. Some of the interviews involved all 4 siblings, through snowball sampling, which is people recruiting their relatives and family to share with us their thoughts. And also involved people with lived experiences in the production of film performances that reflected these experiences, one of which we will be sharing with you later on today. This is so that we can have a direct impact on the dementia care education at Cardiff University, and we're piloting the impact of the dramatization of patient experience onto empathy and awareness of dementia among the students. So in our analysis, we focus on intersectionality, similarities and differences between the equality strands, health inequalities as they relate to access and experiences. We're drawing on the sociology of stigma to better understand the long-term impact of discrimination on current experiences of dementia, and also the performance of kinship, which is sociobiological expectations, performance, and acceptability of caring roles, all of which are disrupted by dementia as a chronic condition and by health inequalities, which also intercept in the way people can carry out what they perceive as the expectation of a caring role as well. I'd like to add a disclaimer before we go on to the findings, which is that this is a small engagement project, even though it ended up taking most of our lives for a year. But the project did not seek to evaluate dementia care, but to understand participant experiences and engagement preferences. Some of the experiences that we will talk about refer to incidents that happened up to 20 years ago, where awareness of equalities was limited among staff. We're also acknowledging something that was shared to us very strongly, that institutional constraints do not allow health and care staff to spend the adequate amount of one-to-one time that is required to achieve good quality of person-centered dementia care. And we also are aware about existing efforts to improve the nurse-staff ratio in dementia care. So what we're focused on is providing evidence of modifiable practices that are easy to achieve and can maximize improvements in dementia care. So I'm going to start with dementia and sexuality. Something that became very clear to us is that the experience of aging as an LGBT elder is very much influenced, not so much also from the current practice, but also from a history of religious and cultural homophobic discrimination, which makes LGBT elders wary of closed institutions, such as hospital wards and care homes. When people go back to the closet, so when they enter a care home, this is often because they are afraid that they might experience discrimination and violence, which was something that was commonly experienced 30 years ago. So as I mentioned earlier, the most recent memories go as dementia progresses. So this means that, let's say, an elder with dementia in 2020 might live in 1980, for example. And the memories of 1980 of homophobic discrimination will be very strong. Many LGBT elders describe that they wouldn't want to be seen like they're making a fuss. But more commonly on current experiences, there was some levels of covert discrimination or low-level discrimination, which were experienced as when hospital and care home staff assumed that same-sex next of kin were friends, did not ask further out of embarrassment, and also even when they knew that the same-sex couple were not friends, they would insist on calling them friends as well. So that further inhibited people to disclose and assert that the same-sex relative and carer is indeed a partner. Going on to ethnicity, we and language as well, our engagement focused on 5 groups. If we include also the linguistic, the different linguistic groups. So that's Bengalis and Somalis, Greeks, native Welsh speakers, and the Afro-Caribbean community. So many of the Bengali and Somali carers of people with dementia described positive experiences, but also made very strong cultural and religious references to looking after one's parents. So that meant that they did not have the expectation from the state and public services to look after an elder with dementia. And it was a whole family affair as well. Looking into people with different languages, different native tongues, what was interesting is that the experiences of Greek people with dementia were similar to native Welsh speakers, which is that the elders were reverting to their mother tongue, And often the hospital staff did not understand that they are still able to understand English, even though they speak in a different language, and did not explain the process to them, and did not identify a member of staff who might not be on the same ward, who would be able to converse in the patient's mother tongue. And that led to increased agitation. So one of our modifiable suggestions is to create an inventory of spoken languages among staff, and to be able to deploy them accordingly, as it can make a very big difference to dementia care as well, especially in the managing of agitation. On the Afro-Caribbean communities' experiences, there were issues of the care of frail and the elderly who do not have next of kin living closely. There was a lack of appropriate services, and especially when there was fractured intergenerational communication. We also heard stories of discrimination as well. For example, in a care home, an Afro-Caribbean elder was subjected to racial abuse from another care home resident who also had dementia, and the staff did not intervene because it was attributed to dementia, and this caused severe distress to the care home resident as well, and intervention had to take in place. Now, Suzanne will talk to you about a report that she produced for the Welsh government as I walk the last mile of the way.
Remember to unmute. Okay, thank you. Yes, this report is been recently produced, and it's the report is a collection of interviews from families who have borne witness to and experienced the devastating impact that dementia has on their families. And the questions that were asked for these interviews were taken from the Black Asian Minority Ethnic Dementia Project from the All Party Parliamentary Group on Dementia, called Dementia Does Not Discriminate, and it was about the experiences of Black, Asian, minority ethnic communities. And there were 9 questions in all, but I have 2 slides, so I just broke them down about what the factors are, if any, which stop people from the African Caribbean communities seeking early help and intervention and or getting a diagnosis. And as we can see, some of the key themes was denial or conflation with old age. They didn't understand about it. They didn't even know it was an illness. And as we all know, I think, and maybe part of the reason why sometimes we might present in crisis is because we make reasons and excuses for each other, don't we? I'm very forgetful anyway, but you know, my family say, oh, don't take note of her, she blah, 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 does this and that. And I think we do that a lot, but then if we don't know it's an illness, or we think it's part of getting older, we just expect those things and we don't do anything about it. But as well as being denial and didn't understand about it, there's stigma attached to it as well, because maybe people think it's a mental health thing, so they don't want to go to the doctors, because mental health causes stigma. There's internal stigma and there's the wider stigma as well, so people don't want to disclose anything about that. Like I say, the bad genes, or depending what culture you might have, or religion, you might think is a comeuppance for things that you did or your family did in the past. So you just think it's part and parcel of you getting old, and you deserve whatever you get, because there is that as well. The avoidance of seeking help, worry about what other people think. I don't want the professional to think I'm an obnoxious Black person, and that's awful, isn't it, to think that. But because there is negative stereotyping around Black people, especially around Black males, mad, bad and dangerous, this is part of the thought processes of not disclosing, not using services. So that was for the first question about the factors which might stop people stop people going, and the lack of openness as well, that they're too proud to go. As you can see here, a white man's illness, thought it was a Caucasian illness. I didn't think it was a black thing. So that's another thing, and I've seen this with mental health as well, that a lot of black people thought that mental illness was a white thing and didn't disclose and didn't come forward to services. Lack of connection with healthcare providers. Some people said they received the news better from someone who looks like them. They take it more on board because there was a criticism that a lot of advertising, the advertising on brochures, nobody reflected their families, so they didn't think the service was for them. And if a white person is telling them A, B, and C, well, they don't think it applies to them. They've never seen themselves reflected in the literature for those illnesses. They haven't seen any of the workers associated with those illnesses. So that's why they don't always think it's for them, and they would like more of a diverse workforce and to see diverse images as well. Spirituality and protection from God. Someone really did think that she's a Christian, so she couldn't get it because her belief in God was so great, and God will cure all. God will send an answer. So until that happened, she wasn't going anywhere. Then, of course, I mentioned earlier on, there's the pride as well, because of that internal stigma. You feel like you've let yourself down, you're showing your family up, and then you don't want to come forward at all. Then the language, and somebody actually said, no one speaks patois in the care home. Will they understand my mother? And this is something that's quite common as well, because I know a lot of Caribbean families do speak patois, and their families can understand that patois. And I think, as Sophia mentioned earlier on, if you lose your language, if you lose your English, you revert back to something that you learned in the beginning, or what's more familiar to you. So the language issue is a huge problem, not just with African Caribbean communities, but with lots of other communities, just like Sophia said, with the Greek community as well. So the report is quite vast. There are lots of interviews in it, and is with African, Caribbean, Yemeni, and there is the Greek and the Asian in there as well. Thank you.
Thank you, Suzanne. Yes, and we'll be sharing a link to the report as well that includes all our findings to the participants who want it. So as I mentioned earlier, also one of the specializations that we bring in this project is arts and health. There is a lot of evidence that creative and visual methodologies can help participants tap into hard experiences that are very hard to express and reach wider audience through different modes of data visualization. So as I said, we work with participants and with artists to use creativity to explore how do participants want to get involved and how do they want to communicate their experiences. So some participants created their experiences directly, and I'll share some of that with you in a minute. Others gave us permission to use their testimonials for other artists to work on them. And then they came back as editors of the script and or as performers. So, so let me share with you the power of some of the testimonials. So Jess Brown is the Chief Executive Officer of the only Afro-Caribbean specialist dementia service in London. So she's involved in advocacy, and she worked with an artist to create 3 pieces. She wanted to focus on the identities of African Caribbean people who came to the United Kingdom as British citizens, and their livelihoods have been eroded by terms such as immigrants, BME, BAME, and other derogatory terms. The artwork that she wants to share is shares the stories of a generation of people subjected to racism in every aspect of life, from arrival as young, ambitious people through to pensioners living with dementia. So I'll just give you a minute to read through her piece. So it's focusing on the stolen identities. And then that's the second piece, acronyms versus reality. And how the use of acronyms, even though it is meant to help to understand, often it can lead to the dehumanization of very diverse groups that are aggregated under one acronym. And another way where we used the arts is we collaborated with a local poet, Ali, and he created poems based on some of the experiences that we heard. And I will share with you one of his poems now.
My mother was the matriarch of this family. Well-dressed, proud smile, standing tall on Butte Street. So proud she was, she wouldn't accept a hand, a trait that she took from her late husband. The day came when we asked for help to the care workers we knelt. We told them how her condition was starting to deteriorate. Dementia, Alzheimer's, they would say. To our knees, we fell again. And what we saw was shocking. With all the elderly patients across the floor, neglected and disrespected, food left by their feet, unable to reach, half-clothed women in gowns, embarrassed by their naked bodies as men would walk around. A stench fills the room. She sat there in her own waste, and the caregivers walk away. Is this where I'm going to leave my mother?
So this powerful testimonial is based on real experiences, and unfortunately, some of these experiences that were shared with us from Afro-Caribbean carers were also shared by people who had experiences of sensory loss, particularly sight loss and hearing loss. More specifically, on sight loss, and Anne will talk more about it in a minute as well, is that there were issues with dignity and privacy, and the assumption that because blind people with dementia cannot see, then it didn't matter if others saw them in a compromised state of undress. And this issue of the state of undress was also expressed to us by members of the deaf community as well, where also there were very prominent issues with communication, limited use of BSL interpretation and understanding of lip reading, staff addressing hearing family members instead of deaf carers with primary responsibility for the person with dementia, limited access to secure environments through audit and intercoms. We also spoke with people from the Down Syndrome Association, and what they mentioned was that the main issue with Down syndrome and dementia is the diagnosis, because it presents early in adults with dementia around 30 or 40 years of age. And even though there are very well organized specialist services in primary care, it can be under or over-diagnosed because of the coexistence with a learning disability. So Anne will talk to you a little bit more now about her experiences caring for her mother, who was registered visually impaired.
Hi, I'm a fairly recently bereaved carer. My mum, who had vascular dementia, experienced discrimination because she was treated less favourably because she had sight loss. So her individual needs weren't met. For example, when she was in the hospital, she would often be given treatment by people who, including injections, by people who wouldn't tell her what they were going to do or who they were. And so, not unnaturally, when she resisted, she was labelled as a difficult patient. Her human needs weren't met either. Her original social worker refused to engage with her or with us as her family. And as a result, my mum ended up in a residential placement for 18 months for no good reason and without her consent. And during that time, her husband died. And while she was expressing grief, including self-harming, I was told by a mental health social worker that she wouldn't be able to remember my father, so she didn't really need any support. So her dignity was also not respected. As Sophia has outlined, people are who have been surveyed here have often had experiences of their loved ones being left partially clothed. That happened to my mum, and in actual fact, we had one incident where she was taken to the toilet on an open ward, and the door was left open. And when questioned, the nurse said that that was for safeguarding reasons, but that doesn't follow any safeguarding policy that I've ever actually come across, and it certainly didn't enhance her dignity. So the Equality Act and the Human Rights Act gives people certain rights, which include not to experience discrimination and to be treated with dignity and respect. But that hasn't been our experience in terms of her care. There were some positives when she was allowed, my mum was allowed home by the Court of Protection finally. And we had a new social worker. That social worker treated my mum really very well and was very respectful of her needs, engaged with her very well, and made all the difference in her life. I'm done.
And also I'd like to say that the project going across 3 equality strands was Anne's idea because of the breadth of her experience as a children's social worker and also her work with the Alzheimer Society. And we drew a lot on her experience of working across equality strands as well.
While I was at the Alzheimer Society, I worked with diverse communities in order, across the 9 strands, in order to try and make services more accessible to individuals and in order to ensure that people had their individual needs met, which is fundamental, really. All groups who have protected characteristics have experienced historic discrimination, and those people who are covered by more than one strand have even more barriers which they experience, and they have more difficulties in accessing services as a result.
So that became quite clear to us that there were these experiences and that they had to be communicated. So we produced 3 short films, and we will also be sharing the links later on, looking at communication in dementia care. And we've also produced a digital story to accompany the films. a group working on dementia care in Canada evaluated a 12-week drama-based educational intervention to introduce dementia practitioners to person-centered care that emphasizes the notion of embodied selfhood, defined as non-verbal self-expression, which is key for people with dementia. What they found was that using the drama-based education created new awareness that the residents' body movements and dispositions can convey meaning. It sought biographical information from family, so it encouraged the professionals to do that. It increased time efficiency and reported, and they supported the residents' independence. So we cannot claim that we will have this impact to professionals who will watch our films, but this is what we hope for in the development of Next of Kin, which is a 5-minute film that's based on testimonials of people who are deaf and hard of hearing, and it highlights the difficulty in communication and how the lack of interpretation and good communication deprive them of the right to be equally involved in the end of their loved one's life and the impact that it still has on their lives now. So something that happens because there's lack of staff, there's lack of time, there's lack of awareness, there is discrimination, either conscious or unconscious, can impact whole families' lives and mental health, their ability to manage the physical health for many decades to come. And this is where our work comes in, to use creativity and social science to intercept these health inequalities.
Anyway, it'd be so much better when you moved to the care home. Plus, it'd be so close, so I get to see you more. Dad, you can't cope on your own anymore. I know it's hard, since Mum gone. When you move, I will get to see you, take better care of you.
What are you doing? Just leave that alone, please. Just get out of there. Just leave that alone. Will you just... Your mother won't be moving. I can tell you that now. Are you listening to me? We're not moving.
Dad, why did you do that? What did you do that for?
You never listen, do you? You never listen.
Dad, I just come from the care home and they told me that you got rushed in. I didn't know anything about it. Why are you on the floor? Why is my dad on the floor? What? What do you mean dementia? Nobody told me you had dementia.
James, take me home, please.
I need to speak to someone about my father. His treatment, his dementia. Why will I told anything? Look at me so I can read their lips. Why will I told about dementia? That's ridiculous. I need to speak to someone. His treatment, his dementia. Do you know sign language? Sign language interpreter? No, I'm his next of kin. He's my father. I'm the next of kin.
I don't want to be here. Where are you? James. James. I don't want to be James, here. Where are you? James, please. Please come and take me away, please.
So this is one of the 3 films that we produced, and we're reaching the end of our presentation. We'd like to thank you for joining us in this sharing journey. Just a few words to conclude. What we found was that respect, dignity, and equality of lack of in the care encounter remain in the extended family's memory for a very long time. Discriminatory experiences lead to negative outcomes and service avoidance. Underrepresentation is system-led, not knowledge deficit-led. And people can live well with dementia, but this can only happen with the right support, and we can be part of it. So Suzanne will give us some closing thoughts on what we can all do to better support people with dementia.
And this comes from how can these factors be overcome? How can we? And not being afraid of approaching someone because the colour of their skin was something that was reported back to us in our report, because that's how they felt that services treated them. Knowing about the person to organise some family activities. Importance of food from the culture of the person with dementia. Engage in familiar cultural activities. Example is that there's knitting workshops we could have. Staff speaking in community languages, that is Welsh, Patois, BSL, Arabic. Diverse magazines in care homes or hospitals, etc. It'd be good to see a range of magazines to reflect the communities that they're serving. Train up families who have lived experience to go into communities. Again, that's people, a diverse group of people speaking to other diverse people, whether the message can be taken more seriously and understood. Have images that look like us in your promotional materials. Have some support groups, raise awareness, getting Black professionals to talk about it. Black people delivering services, we come again to having somebody who looks like us, and Black people with lived experience to break down the stigma, to know that if it's okay for us, it's okay for you. Thank you.
So just to finish, we'd like to acknowledge our funders, our project partners, all the third sector organizations who have supported us on our journey, our creative partners, and our research partners as well. And this is the end of our presentation, and we look forward to answering your questions.
Thank you to all the presenters. That was really interesting. Films looked really good, really powerful. So I'm going to go through, there's a couple of questions already in the chat, and if people have got additional questions, comments, observations they want to make, then please do pop them in the chat and I'll do my best to get through them. So I think you answered this one, Sophia, in the presentation, but just to double check. So Joanna Waring has asked, will the slides be available afterwards, because she'd like to discuss them, disseminate them with colleagues in her team. I think you said they were, is that right?
We will disseminate the report as I walk the last mile. And also I would like to also share the YouTube videos of the films, but as we are still preparing our impact questionnaire, if it's okay with the participants, I'd like to share with them the impact questionnaire together with the films when it's ready. So that might happen within the next month.
Great, that sounds really good. Thank you for that. And there's a question here from Ira Hopkins-Jones, who asks, why is it that dementia is diagnosed within mental health services rather than GP primary care? And Ira comments that her question is because it's an illness, dementia is an illness, not a mental illness after all. So what are your thoughts from the panelists on that? Why is dementia diagnosed within mental health services and not GP primary care?
I think, Anne, you might be able to better answer this question.
Well, I think the straight answer to that is that is the way that the structure was established, and that in some ways our services are quite rigid in the way that they view individuals and patterns of behaviour. So, I mean, for example, disabled people are lumped as one homogenous group, and I think, you know, people with dementia have become kind of the victim of the same thing, that it relates to diseases of the brain, so therefore it must relate to mental health.
Yeah, thanks, Anne. Any other thoughts from Sophia or Suzanne on that? That's a comprehensive answer.
I think as well, it's because of the way dementia can present itself, and doctors, GPs are general practitioners, not specialists. Not that mental health services are specialists of dementia, because dementia, as we say, and mental health issues are two different things. But I think maybe that the mental health services have had, might have had training around certain aspects of behaviour, certain aspects of thought processes, where a general practitioner does not. But I'm not really sure.
Thank you for that. A comment, I think, on the same topic about that, which is that, you know, memory teams. Joanna, I think, probably worked in a memory team. Is saying that memory team isn't mental health; that they work in partnership with them. So, you know, have GPs who are also seeing people in primary care settings. So I guess the case being made that you know, those diagnoses can come from primary health sometimes. I think. Notwithstanding what you've just said, obviously. Couple of just positive comments about, you know, very informative, emotive presentation, people getting a lot from it, looking forward to reading the full report. So thank you again to panelists. A question from Lillian, again saying thank you for an insightful session. Asking about, I think Suzanne, you were talking about some of these stats near the beginning. Why are people from ethnic minorities more impacted by or more susceptible to dementia than white people? And what steps have been made to address that you know of, or what steps do you think should be made?
A lot of the issues is because of lifestyle and health outcomes. We're more susceptible to high blood pressure, and part of that is, I think, it's been researched, and I think that was to do with a lot of people and food and high fat content and high deep fried and lots of fat. I think too much fat, and then causing strokes or heart disease, because it seems like the Black, Asian, minority ethnic communities seem to be prevalent in those areas of illnesses, and those areas of illnesses gives us more risk of contracting dementia. So I think that those are the issues that our communities face, because one of the things that was fed back in the report was somebody saying that we should collaborate with the British Heart Foundations to make some of the foods that the groups eat, to make them more healthier and not as fattening, I suppose, so that they can still eat the same food, but it's not a health risk for the way that it's cooked and the way that it's prepared. So I think because then that might give us the high blood pressure, the heart disease, the strokes, those things. So those are the reasons why.
Can I just add a quick point to that? From my working experience, also an issue is the fact that people, because they don't have access to services, then diagnosis comes later, so outcomes are not as good, and so that makes a much bigger impact.
Yeah, that really valuable point. Thank you, Anne. And Lillian, kind of continuing that discussion in the chat, is saying, Lillian herself from African descent says, very true, recognizing that, the diets are changing drastically within some communities, but also maybe seeing that, in older generations, something like dementia was much less discussed, maybe less, maybe not heard of, and now it becoming this much more common thing to talk about. Another question here, or a couple of more questions here. We've still got a few minutes left. So Kemba is asking, is there evidence or research that Afro-Caribbean living in Caribbean countries, as opposed to communities of Afro-Caribbean people in the UK, are also at high risk of dementia? Or is there something about being in an Afro-Caribbean community in the UK that puts you at high risk? Or do you see that in other countries, I guess is the question.
I don't know about that. I do know that dementia is diagnosed every 3 seconds around the world. So it would seem that, it's in all the countries. It might, I don't know if it's as prevalent as it might be in the UK. And, as we know, the numbers are going up in the next 25 to 30 years, 7-fold in the Black communities than in the white communities. So I would say that it's all across the world, really the thing. But I don't know that as a fact.
Sure. Another question here, again along the same lines, I think, really, but talking about the need for preventative measures, to try and maybe tackle some of those root causes if it's linked to things like social deprivation, inequality in terms of diets and things like that, which we know can be linked to poverty often. This is me talking, like, what do I know? I'm not one of the presenters, you can tell me I'm wrong, but it sounds like more preventative measures are needed. That's the question. Is it a bit like other health conditions in that regard, that the medical treatment in a sense comes at perhaps at later stage once there's already been a diagnosis? That's obviously what individuals need. What's your view on that question, really? The actual solution, not that there would be one, but is it about social inequalities?
When Sofia sends out the link for the report, I've also made 2 posters back to back. One is about early signs of dementia. There's about 10 on there, but then there's lots of other things, but that's one of them. Then on the other side is about dementia prevention, and that talks about keeping yourself healthy, keeping yourself fit, and lots of other things. I think there's four things on the poster, so you can have that poster to be sent out with the report.
And I can't emphasize enough that actually meeting people's individual needs is a really good way at an early stage of of preventing the triggers, which include as has been said, a stroke for vascular dementia, but also managing early onset dementia.
Mm-hmm. Yeah, that makes a lot of sense. So we're just about out of time. If someone's got a burning question, you've probably got time just to put it in the chat now, but that'll probably be your last opportunity. But thank you again to Suzanne, to Sofia, to Anne for coming along today, sharing your research, sharing your videos, offering to share the reports in future, the slides, the posters, all the resources that you're going to make available. It sounds like a recording of the webinar will be on the YouTube channel as well as soon as that's ready. Thank you to Sian and Rianne, who have been hovering around in the background and made sure everything worked from a technical point of view, and were there as a safety net for me as the host, I think, in case anything went wrong. And I certainly appreciated that. Thank you to everyone who came along. It's been a really interesting webinar, And I'm sure there's lots more exchange content on the website for people who are interested in webinars and interested particularly in adult social care, dementia, that kind of intersection. Lots of people saying thank you very much in the chat. Very interesting. Well, you can see those as well as panelists, can't you? People are very grateful for your time and commenting.